Good afternoon and welcome to the June P&T meeting for the Oregon Health Authority. My name is Roger Citron. I'm the director of the Drug Use Research and Management Group. We have all of our committee members in attendance, and this meeting is being recorded. So for those of you in the audience, if you're able, please add your affiliation after your full name. That will let us accurately reflect that for the minutes. We do have a pretty good agenda, so we're going to get started with roll call and introductions. On the screen is the committee. Pat and Kat are not able to join us today. So Stacy, as long as you have power, we'll leave it to you.
Well, my phone is hanging in there, so no power yet. Hi,
All right.
everybody. I'm Stacy Ramirez. I am faculty at OSU College of Pharmacy and the Director of Clinical Services for Vital Sync Health. And yes, please bear with me. My power went out at exactly 12:57, just as I was logging in. So I'm relying on my 25% battery cell phone. So
I
we're
hope
going.
it hangs in there. Thank you. Tim?
Good day, this is Tim Langford. I am the pharmacy director with the Klamath Tribes.
Welcome, Tim. Bridget?
Hi, my name is Bridget Bradley. I'm a psychiatric pharmacist at Kaiser Northwest.
Welcome, Bridget. And Samara?
Hi, I'm Samara Stevens. I am a naturopath in private practice in North Portland.
Welcome, Samara. Jeannie?
Sorry, it took a minute to come off mute. Are you able to hear me okay?
You
still?
bet. We got you again.
Okay, great. Jeannie Savage, she and her pronouns, Chief Medical Officer for Trillium and a family medicine physician. Thank you so much.
Welcome, Jeannie. Doug?
I'm Doug Carr, medical director at Umpqua Health. I'm an internist.
Welcome, Doug. Russ?
Hey there, I'm Russ Huffman. I use he, him pronouns, and I'm a psychiatric nurse practitioner at Salem Health.
Welcome, Russ. Eriko?
Hi, I'm Eriko Nishi from Family Medicine, OHSU.
Welcome. And Eddie?
Hi, good afternoon. Eddie Saito, Associate Professor at Pacific University School of Pharmacy and Clinical Pharmacist with Virginia Garcia.
Welcome all. And we'll do some staff introductions. Jennifer, I'll let you lead off.
Jennifer Bowen, Executive Support Specialist with the Oregon Health Authority.
Roger Citron, Drug Use Research and Management Program, and I'm going to go off video so it's not so distracting.
Hi, everybody. I'm Trevor Douglas. I am the Pharmacy Director at the Oregon Health Authority.
Good afternoon. I'm Dave Ingen, a clinical pharmacist with the OSU Derm team.
Hi, I'm Sarah Fletcher. I'm one of the clinical co-coordinators for the Derm team.
This is Andrew Gibler. I'm the clinical pharmacy manager at OHA.
Hi there. My name is Kyle Hamilton, and I'm the pharmacy drug coordinator at OHA.
Dan and Megan aren't here, so Deanna, we'll turn it over to you.
Good afternoon. I'm Deanna Moretz. I'm one of the pharmacists that works with the Derm team.
Hi, I'm Kathy Centena, and I'm also a clinical pharmacist with the Derm team.
Hi, my name is Sarah Servid. I am also with the Derm group as one of the P&T clinical coordinators.
Hi, I'm Lance Starkweather, pharmacy manager for Gainwell Technologies.
Dee is stretched thin with lots of other priorities, so she is not able to join us. So Brandon, we'll turn to you.
Hello, I'm Brandon Wells. I'm the Pharmacy Programs and Operations Analyst for the Fee-for-Service program at OHA.
No TED today, so no TED Talk. Michael, I'll turn it to you.
Thanks, Roger. Hi, everyone. It's nice to be with all of you today. My name is Michael Yu. My pronouns are he, him, his, and I'm the Community Pharmacy Liaison for the Oregon Health Authority.
Excellent. Next, if you're following along, we have a packet of materials that's been posted to our website where we had this meeting information. I'll call out different parts of the meeting and where those reference pages are. So we're now to the conflict of interest declaration. Conflictors of interests are vitally important to the OHA. All of the staff have current conflict of interest declarations on file, as do the P&T committee members. And anybody wishing to provide public comment today or written testimony was required to submit conflict of interest declarations. But with that, we still provide an opportunity at this time to see if any of the committee members have any conflicts that are fresh and new and need to be disclosed to the OHA. Hearing none as expected, we'll move on. We have the agenda starting on page 4 in the packet of materials. So we have the approval of this agenda. No changes are anticipated. And the minutes from the last P&T meeting in April were submitted to the committee in advance. They had an opportunity to review. Need to see if the committee has any edits they'd like to recommend. And if not, we'd entertain a motion to approve.
Move for approval.
Appreciate it, Doug.
This is Jean Neal, second.
Thank you.
All those in favor?
Aye.
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 Opposed? Abstain? All right, thank you.
Fantastic. Next, we're going to turn it over to Andrew Gibbler for the department update.
Thank you, Roger. Again, thank you so much, everyone, for volunteering your time to serve on this committee. I know there's a million important things you could be doing right now, but we really appreciate your effort and your engagement on caring for Medicaid policies and Medicaid patients, and so wanted to thank you for that. And I know there's been a lot of news around pharmacy closures. I think that's an important topic and consideration, especially with the announcement of Rite Aid closing in Oregon, and of course that delays access to prescriptions and really decreases our public health capacity. So just wanted to let committee members know that our program monitors these closures and we assess the possible impacts and are engaging key parties as appropriate. And if any of you have any questions about the closures or impacts or what we're doing in these efforts to help mitigate some of the impacts the best that we can, then please feel free to reach out to Trevor Douglas, and he'd be happy to talk with you and provide more details on our efforts. In regards to the Mental Health Clinical Advisory Group, wanted to announce a recent vacancy for a clinical psychologist. And so if any of you know a clinical psychologist that might be interested in serving on this group, I would really appreciate you and your efforts. This is one of the ways that we can get the information out for vacancies as they come up. So we'll appreciate that. And we always have our current vacancies or upcoming vacancies available on our homepage. So you can always go to that and see what might be available. And then in terms of the group's efforts and publications since the P&T Committee last met, back in February, the FDA removed the REMS, the Risk Evaluation Mitigation Strategy Program, for clozapine, and so the Mental Health Clinical Advisory Group adopted some guidance around monitoring for patients on clozapine. I think most mental health providers felt the REMS program probably placed an excessive focus on neutropenia and was overly burdensome monitoring, had overly burdensome monitoring parameters. And so the guidance that this group adopted is from the European Clozapine Task Force, which they report to the European Medicines Agency, which is Europe's FDA equivalent. And this group formed some more flexible and less cumbersome monitoring schedule for clozapine. And so that guidance was also adopted and recommended by the Mental Health Clinical Advisory Group, as well as several CCOs in Oregon. And so that's been published on our webpage as well. And so we're hopefully that will expand clozapine access to patients with treatment-resistant schizophrenia who are probably deterred previously due to the monitoring parameters associated with it. In terms of, I don't have any legislative updates. If Dee is not here, I don't have anything to provide. I know we're winding down now. Trevor, do you have anything else you would like to add to anything that I haven't mentioned yet?
No, Andrew, I think you did a great job. Thank you.
Okay. Okay, Roger, back to you.
Great. Thank you, Andrew. Again, one more plug for those of you in the audience. If you can, please add your full name and your affiliation. That way it lets it capture that for the minutes. So if you're following along on the packet of materials, we're next going to page 8 in the packet. And this is part of our consent agenda. It lets us have a little efficiencies in these process. It includes our quarterly DUR report, as well as new additions to our oncology policy and orphan drug policy. So we would welcome a motion to approve those additions. Unless the committee member wishes to discuss it.
Motion to approve.
Appreciate it, Eddie.
Second.
Thanks, Doug.
All those in favor?
Aye.
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 Abstain? All right, thank you.
Great. As I mentioned at the top of the order, the P&T Committee does serve as our DUR board, so we focus one meeting each quarter as federally required on DUR activities. So turn your attention to page 28 in the packet, and we have our prospective DUR report, and that was prepared and will be presented by Lan from Gainwell.
Thanks, Roger. So here is the high-level summary of the DUR alerts for the quarter. We're talking about first quarter of 25. Basically, 186,000 DUR alerts were registered in the pharmacy point of sale. 62% of those were due to the early refill, which is the first highlighted yellow row. 116,000 alerts hit the system, 27,000 were overridden, a 23.6% override. The second highlighted row is the pregnancy drug category, and that also is set to deny the claim, and it requires a pharmacist intervention. We had 150 alerts for that, and 66 were overridden. Next page. This page just summarizes the top drugs that are enforced in the early refill DUR alerts, and they're categorized by the different therapeutic classes. The first two table is for the antidepressants. The first one is the SSRIs, and then the second table encompasses the other antidepressants. Majority of these were the 25% of it was overridden for these drugs. Then we have the antipsychotics, second generation antipsychotics. Majority of that is also overridden due to changes in therapy. Any questions on the early refill? Next page, please. Here we have the early refill override reason codes. These are entered in by the pharmacist to indicate why it's being overridden. Majority of this has to do with medical necessity, which is the submission clarification of 7. 78.4% was due to that. Next was the 11.7% due to change in therapy, so submission clarification of 5. And then lastly, this is the cost savings due to the ProDUR. Overall for January, 153 prescriptions were not dispensed. That was 53,000 cost savings to the state. February had 195, it's 59,000, and then March had 92, and that's 17,000 overall for the first quarter, $129,000 in cost savings for the ProDUR. Any questions on the ProDUR?
Great, thank you, Lan. Next, we have our retrospective DUR report, page 32, if you're following along on the packet of materials. And Dave Engen, we'll turn it over to you.
All right, thank you, Roger. We're on, page 32. And for this retrodur report, we're looking at Q2 data. So that's January through March of this year. As usual, I'll just hit the high points of this report. And on this page, you'll see a billing correction review initiative. Keep track of high dollar claims that may have been billed incorrectly for patients that might have other coverage. We're capturing different types of billing issues and different scenarios with hopes to capture savings over time. We'll dig more into these claims and reach out to the providers. Some numbers there. Page 33. That's our change forms to alert providers to change to more cost-effective formulation. We have a few of those still going in the background, but we're looking to add some more opportunities there. Page 34. This captures our messaging to prescribers about dose consolidation. We recorded just one fax going out because the messaging is really going on at point of sale right now at the pharmacies. Page 35. This is our expert consultation referral for long-term antipsychotic use in kids. See lots of patients screened, but a handful are flagged as high risk. And you'll see about a half dozen or so prescribers received a referral to Opal K for a consult. And if you go to page 36, that's our messaging to prescribers about patient non-adherence to their antipsychotics. We're seeing about half the patients refill their medication the next 90 days after the prescriber is notified. Numbers there. So page 37, this lists the different kinds of individualized profile reviews for children in foster care and patients with a variety of high-risk conditions. Could be bipolar, polypharmacy, or chronic opioids, those types of things. Staying fairly consistent quarter over quarter, and we'll continue to send out alerts and recommendations as they present themselves. Page 38, this is our safety net program for antipsychotics in really young children. Once again, if we know a PA is ending, we try to proactively notify prescribers to submit a new PA for their patient and then identify what info they would need so patients get the appropriate care and no interruption in therapy. You'll see most of the prescribers identified were notified, and about half the patients ended up with paid claims in the next 60 days. And on page 39, lastly, we report on this, the safety net monitoring. First one's for patients on dangerous opioids, sedative combos. About a third of those prescription combinations are being discontinued within 3 months after notification. We started to track new naloxone prescriptions as well in there. You'll see there's a few prescribers being notified their patient's been denied an oncology med with no evidence of a new fill for an alternative agent. And then we do the same type of thing for prescribers whose pediatric patients were denied a TCA, but no alternative was filled or requested. We're seeing out of the 5 notified, 4 of the patients either received their TCA or an alternate in the next 3 months. And so really that's the summary of the retrodur report. As always, if you hear of new opportunities in this space, please let us know. And we'd love to investigate new ideas. We're always looking for new ways to intervene and cost savings. So if there's no other questions, I'll turn it back over to Roger.
Thank you, Dave. Any questions on the retrodur report? All right. One additional component of drug use review is educational initiatives. And one of the ways that we accomplish this is through our newsletters. So I draw your attention to starting on page 40 in the packet, and we'll turn it over to our editor, Kathy Centena.
Great, thanks, Roger. So today we're going to recap 3 newsletters briefly. Back in October of 2024, we published a newsletter on new and emerging therapies for metabolic dysfunction associated sciatic liver disease, also known as MASLD, as well as metabolic dysfunction associated steatohepatitis, also known as MASH or MASH, in adults. This newsletter was a great discussion on the new treatment options for these diagnoses, including the GLP-RAs, as well as resmetirom. Sorry. The second newsletter was published in November of 2024, and that was an update on the biosimilar landscape in the United States market. This does start on page 44 in your packet. This newsletter reviewed recent trends in the biosimilar market, as well as some changes that we made or that we outlined from the Oregon Health Plan fee-for-service population on policies related to the targeted immune modulators, as well as those policies affecting autoimmune conditions. The third newsletter was published in December of 2024, and that was on a review of off-label uses of gabapentin as well as pregabalin. The newsletter focused on the evidence for the off-label uses of these drugs, as well as highlighting the different disease states, which there is demonstrated evidence of benefit versus those disease states that had some insufficient data. So again, thanks so much to authors who assisted in providing these important provider education pieces, as well as for the committee who provides their feedback and suggestions. You can sign up on our website to receive these newsletters electronically. And then I also encourage you to take a look at our newly posted newsletter on medication safety. And then, of course, we always like to get ideas from committee members on topics that they think may be helpful to providers. So if any of the members have recommendations, we'd love to hear them now or via email. Any hot topics?
Always get good ideas from the committee. Also, technical difficulties on our side. I just want to engage Sarah Fletcher, if you can jump in and start to assist with posting videos. We've got some electronic issues on our side. So I think Mercury's in retrograde. I got Stacy and now it's getting us. So pause with us for just a second while we transition presentation of our slides. And again, give a little more of a brief pause for the committee. If you have any ideas for newsletters, timely topics that would be of interest to you, that might be to other providers and the public as well.
This is Eriko Nishi. I'm personally very interested in the CKD and SGLT1 inhibitor use for people with no proteinuria. I don't know if it's too specific or not, but some interest there.
No, I think there's some new guidelines as well. And I think we were briefly discussing as a team having a newsletter, but appreciate that topic. We'll take that back and discuss it, bring something forward. Again, as we get reoriented with the slides, I think we can do a slide presentation. We do see the slide coming up.
Can you
just
see the slide, or can you see the slide?
All of your bottom slides as well. So
okay, let me adjust some things.
Great, thank you. And I'll briefly touch on DUR for 1 second. This is the time of year when we complete our annual survey for CMS. It was from the previous fiscal year, so October of 23 through September of 24. And in those surveys, they have new questions that kind of flag us for what is important to CMS and what they're looking for. So one of the areas, as we just report, Dave just showed us in our retrodur report, we've been doing work within antipsychotics and children, and CMS is interested for us to be looking in the adult population. So stay tuned. We'll be looking in that space for opportunities and bringing back both initiatives for DUR. Retrospectively is how we've been handling it, but in conjunction with the Mental Health Clinical Advisory Group, I think we'll look for some opportunities to, in fact, maybe engage some edits. So real-time point of sale claims adjudication edits. So that's a space we'll be looking at. So appreciate the slides are back up. If you're following along in the packet of materials, draw your attention to page 51. And Deanna, I'm going to turn it over to you.
Thanks, Roger, and thanks for letting us know there was technical errors. I thought it was on my end when I couldn't see the slides, so good to know. If we can go to the next slide, please. So we are doing this review on actinic keratosis because right now it's currently not funded by the Health Evidence Review Commission. They are evaluating dermatologic conditions today. Their meeting runs concurrently with ours. So at the end of this, I'll summarize what their proposed changes are. So the reason we're bringing this forward is part of the benefit update project, and we're developing PA criteria. So there's a pathway to coverage for actinic keratosis in people that have the EPSDT benefit. Next slide, please. Now, typically, actinic keratosis is seen in older people. It's due to exposure, chronic exposure to ultraviolet radiation. And it's usually the first lesion that leads to a progression of squamous cell skin cancer. So like I said, the prevalence is generally among white people that are 50 years of older, and it's one of the most frequent reasons that people visit a dermatologist. Next slide, please. So this is just a summary of all the different topical agents that we have for treating actinic keratosis. This table is also presented on page 54 of the packet. I'll draw your attention to the 5-FU and imiquimod therapies. They're not only approved for actinic keratosis, but they're also approved to treat basal cell carcinoma in the case of 5-FU, and then for imiquimod, also genital and perianal warts in children and adolescents that are greater than 12 years old. And the specific formulations that are approved for this is on that table there. You can see that generally these creams have to be applied anywhere from 1 month to 3 months, depending on what formulation is used. And then at the very bottom, we have the aminolevulanic acid, which is used in conjunction with photodynamic therapy. And that's generally just a one-time application that's done by the provider. Treatment on these is really the efficacy is really based on adherence. People really need to make sure that they apply these medications as directed when they are prescribed. Unfortunately, the adverse reactions, which include skin swelling, redness, burning, and itching, may make it difficult for people to adhere to that prescribed regimen. We could go to the next slide, please. So there are a total of 3 systematic reviews that provide evidence for the safety and efficacy of topical AK drugs. There is insufficient evidence to directly compare the treatments. Generally, the outcomes that are used to evaluate treatment efficacy include treatment success, which is defined as greater than 75% reduction in the number of lesions from baseline, or mean reduction in the number of lesions, or proportion of patients that have complete clearance. So in that 2009 review, they compared 5-FU cream with other treatments, including imiquimod, cryotherapy, diclofenac, facial resurfacing, photodynamic therapy, and then they also looked at 5-FU augmented with tretinoin and a weaker version of the 5-FU cream. Low quality evidence showed that about half of the patients that used the 5%, which is the strongest 5-FU cream, that they can expect complete clearance, and overall an 80% reduction in lesion count can be expected. Then in 2012, Cochrane did a review that looked at all the different sorts of ways to manage AK lesions, and low quality evidence showed that the 3 topical treatments were equally favored, so 3% diclofenac, 0.5% 5-FU, and 5% imiquimod. They had one randomized control trial that compared the 0.5% versus 5% 5-FU, and they found comparable efficacy and safety. Next slide, please. So in 2022, our most recent systematic review, it compared imiquimod, 5-FU, diclofenac, photodynamic therapy using the aminolevulanic acid formulations, the 20 and the 10% formulations. And they showed that after using imiquimod, that there was fairly decent reduction in the lesions. Same thing with 5-FU. The number was a little bit higher with 5-FU, 80% versus 67 with imiquimod. Again, these were not comparative trials, so they were just looking at, most of these were placebo-controlled trials. And then with diclofenac, the treatment was much lower. So looking at the guidance that's been developed in 2021, the American Academy of Dermatology issued guidance. So they strongly recommend using 5-FU cream or imiquimod cream, and that's a strong recommendation based on moderate quality evidence. They have a conditional recommendation about the use of diclofenac, and that's based on low quality evidence. And they also conditionally recommend using the photodynamic therapy with the aminolevulanic acid over cryosurgery. And then they also issued some guidance about cryosurgery using that in conjunction with 5-FU or imiquimod. And then they also do recommend topical terbinafine. Right now, that product is not rebatable, so we haven't seen a lot of claims for it because Medicaid only covers claims for rebatable drugs. But they did issue some guidance in 2022 about using that drug. Next slide, please. I mentioned earlier that HERC is looking at coverage for actinic keratosis as part of the benefit update project, which will be implemented in 2027. HERC met with some dermatologists who recommended that cryotherapy and photodynamic therapy only be used in patients that have high-risk conditions, which are outlined on the slide here, and if they don't have a sufficient response to topical medication or a contraindication to topical medications. Excuse me. So HERC is recommending treatment with topical medications, for example, 5-FU, be covered for all the actinic keratoses. Next slide, please. So our recommendations are to create a PDL class called topical agents for actinic keratosis. And based on a review of the evidence, we'd like to designate at least one topical formulation of 5-FU and imiquimod, the two products that are indicated for treating basal cell carcinoma and genital warts. We'd like to make those preferred, so there's a pathway to treatment to coverage for those indications. And then we'd like to maintain diclofenac as non-preferred and also add the terbinafine ointment and the aminolevulanic acid gels as non-preferred to the PDL. And we'd also like to implement PA criteria for these non-preferred agents so that we can provide a pathway to coverage for EPSDT. And we will look at medication costs in exec session. So if you go to the next slide, the proposed PA criteria start on page 73 of the packet. So the goal of the PA criteria is just to ensure appropriate drug use and restricted to indications that are supported by the evidence. And then also allow case-by-case review for members that have the EPSDT benefit. The longest duration of authorization we would recommend is 3 months. That's because the diclofenac is recommended to be used for that long. And the PA will just be for the non-preferred agents for pharmacy claims, and then the aminolevulanic ointment for provider-administered claims. Next slide, please. So this table is very similar to the one in the packet, and it was just developed to help Gainwell as they're reviewing claims, so they know what the different dosing parameters are for the different formulations, and also to highlight which two products are approved for basal cell carcinoma. And like I mentioned earlier, the imiquimod is approved for genital warts in children and adults that are over 12 years old. Next slide, please. So the PA criteria are pretty simple, just to ask what diagnosis is being treated. Is it an FDA-approved indication? Have they tried a preferred agent? And if they have, and they have a contraindication or intolerance, then we would continue and go through the next steps. We would ask if it was funded by OHP. And then if they have the EPSDT benefit, of course, they would go to step 5, which is our standard EPSD question to assess if there's documentation that the condition is of sufficient severity that it impacts the patient's health. Next slide, please. Oh, I think that's it. That's all we have. So I would open it up to questions if we have any questions from the P&T committee.
Good job, Deanna. Lots of information. Any questions from the committee? All right, hearing none, we'll go back to the slide with the recommendations. It's
I
to
think
add
there's
this.
there's a recommendation slide in the next one, but that's okay. You can go backwards. I put one at the end too. So anyway,
Oh, great.
just to summarize, we want to create a PDL class of the topical agents and designate at least one 5-FU and imiquimod formulation is preferred, make everything else non-preferred, and implement the PA criteria that I just outlined.
And again, just for clarification, make one topical 5-FU and one imiquimod preferred, but we'll review broadly the class in executive session. Any questions on the recommendations or the PA criteria, or anybody willing to make a motion to approve?
Motion to approve.
Second.
All those in favor?
Aye.
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 Opposed?
Aye.
Oh, sorry. Anyone opposed? Abstain? All right. Thank you all.
Great job. Staying with Deanna as she gets a lot of topics and drawing your attention to page 76 in the packet, I'll do the AGRIFTA SV PA update.
Thanks, Roger. Okay, if we can go to the next slide. So the reason that we're looking at this medication again, it's another part of the benefit plan update. Right now, treatment of HIV-associated lipodystrophy is not funded by HERC. So the drug we're talking about, AGRIFTA or tesamorelin, is the only drug that's approved to treat HIV-associated lipodystrophy. So we're just looking at the PA and updating it to see if there's any recent evidence that would warrant us revising the PA criteria, and then also making sure we add the pathway to treat under EPSDT. So if we can go to the next slide, please. So the HIV-associated lipodystrophy is an adverse effect generally due to using 2 types of antiretroviral therapy, and it causes a redistribution of the adipose tissue. The 2 drugs that are mostly indicated in this condition are stavudine, I know I mangled that, or zidovudine. So in general, replacing the use of those agents with tenofovir or abacavir is the primary medical approach to managing lipodystrophy. Tenofovir and abacavir are the first-line NRTIs because they're efficacious, safe, and they're convenient, where the other 2 medications generally are associated with more adverse events, and they're not as effective in inhibiting the virus. So tesamorelin is a growth hormone factor releasing analog, and its only indication is to reduce the excess abdominal fat that can occur in patients with HIV. We first reviewed this at the 2012 meeting as a abbreviated new drug review. And like I mentioned earlier, this is the only medication that's approved in the United States to treat the abdominal fat accumulation that's seen with HIV treatment. Next slide, please. There was no new evidence since that 2012 review, so the recommendation is basically to revise the PA criteria to define medical necessity and appropriateness for patients with the EPSDT benefit, and we'd like to maintain tesamorelin as non-preferred on the PDL. So next slide, please. So the changes to the PA criteria are highlighted here. We're just revising the goal to say it's to ensure appropriate drug use and restrict it to indications that are supported by the evidence, and then also to allow the case-by-case review for members that have the EPSDT benefit. And then there was another formulation that was released, so we added that. So basically, we just revised question number 2 to say if they have the EPSDT benefit, then they'll go on to question 3, and we just added some more criteria about asking if they have switched to using a different antiretroviral therapy, and have they tried lifestyle changes, for example, diet and exercise. And if they've tried those and they haven't worked, then we will ask the standard EPSDT question about is the condition severe enough to impact the patient's mental or physical health. And then I think we have renewal criteria because we're approving this for 12 months. And the renewal, we don't have renewal criteria. I misspoke. Okay, so basically that's all we have is those criteria. And then the question is, does the P&T committee have any questions about the changes we're making to this PA criteria? I think that's on the next slide.
I'm just curious how often this being used?
Oh, that's a good question. We have 9 patients that have the diagnosis of HIV lipodystrophy. We have no patients that are getting either one of the stavovudine or the zidovudine, and we don't have any patients that are getting the Agrifta right now.
And I'm sorry for the ignorance as well, but like efficacy wise, if this medication is very helpful or lifestyle can what's the effect of this meds and yeah.
From what I read, lifestyle is effective in helping to eliminate the fat tissue that accumulates. But I think the biggest thing is switching therapy to drugs that don't cause this adverse effect. That seems to be the most common recommendation. So
Okay.
to not use those 2 antiretroviral agents that are most often implicated in the HIV lipodystrophy.
And I guess my final question is that who diagnosed this condition? Like, for example, how do you know this is, of course, the patient's being on the medication, but also like with other comorbidities, like how you differentiate obesity and all that stuff? Like who to make that diagnosis is my final question.
That's a great question. I would think probably a physician that specializes in taking care of patients with HIV would be more familiar with what to look for. But I think the redistribution of fat it's pretty clear what's happening there. But I don't know if any other P&T committee members want to answer that because that's not really within my realm of expertise.
Thank you. Sorry, I'm also very
That's okay.
ignorant.
That's okay.
Appreciate the questions. Any other questions for Deanna? All right. We don't have any public comments, so the recommendation again is to revise the testosterone PA criteria to define medical necessity and appropriateness for patients eligible under the EPSDT benefit. Also to maintain the agent as non-preferred on the PMPDP. Discussion or a motion to approve?
Motion to approve.
Thank you, Samara.
Second.
Thank you, Eddie.
All right, all those in favor?
Aye.
Aye.
Hi.
Aye.
Anyone opposed? Abstain? All right, thank you all.
Great. Thanks, Deanna. Next, we'll turn it over to page 81 in the packet of materials, and Kathy Centena, turn it over to you.
Great, thanks, Roger. So yeah, today we're going to be looking at dry eye. We're going to evaluate the evidence related to the treatment of dry eye, which is currently unfunded. So the language you'll see is similar to some that Deanna just had in her AK review. So we're trying to establish a medical necessity pathway for coverage for those EPSCD patients, which can be expanded to that additional population in 2027 when the OHP prioritized list is retired. For this review, this is a new class. We found 2 new systematic reviews and meta-analyses, 2 new guidelines, and then 7 randomized controlled trials. Just a little bit of background on dry eye, since we're looking at this for the first time. These treatments are usually focused on symptom management rather than cure, so they are long-term therapies. The onset of action for these usually range between 1 and 3 months, with the exception of the topical steroids. The important outcomes in dry eye are usually based around symptoms, as far as eye discomfort, dryness, visual impairment. And one of those is the Ocular Surface Disease Index. This is a 12 questions questionnaire that helps to determine the severity of dry eye. It ranges from 0 to 100, with a minimal clinically important difference of about 4.5 to 7.3 for those with mild to moderate dry eye. And then for those with severe dry eye, the MCID ranges from 7.3 to 13.4. The visual analog scale is also used to rank the severity of symptoms of dry eye, with those higher scores indicating more symptoms. And the MCID for this is around 30% change. You also see the Schirmer test referenced here. The tear test helps to measure the rate of tear production in the eye. And then also there's different staining scores. So the fluorescein staining score can assist in the diagnosis of dry eye by highlighting those areas of damage on the ocular surface. The National Eye Institute grading scale is often used, and these domains are graded from 0 to 3 with a maximum of 15 points. When anything above 0 is considered abnormal. The MCID for this is a change of around 1 to 2 points. So the guidelines recommend first line the use of artificial tears for the management of dry eye, which are available over the counter. And then there are a variety of FDA approved prescription products as well that we'll be talking about on the next slide. And then briefly, I just wanted to mention vernal keratoconjunctivitis conjunctivitis, which is an extremely rare condition that can affect patients, usually when they're younger, 5 to 25 years old. And it's an inflammation of the conjunctiva. However, it's very uncommon in the United States and usually seen more in the Middle East, India, Central America. But we did want to mention it here just because one of the newer cyclosporin topicals is indicated for this diagnosis. So looking just briefly at the treatment of dry eye for the prescription products, they do range in the mechanism of action. So we're going to go over that just quickly. The first one's a topical steroid, lopredinol. It just helps obviously with inflammation and prostaglandin production. The second product, lifitegrast, is a lymphocyte function associated antigen 1 antagonist, which what it does is helps to decrease the inflammation on the ocular surface and helps by preventing immune cells from sticking to the eye. Of course, the cyclosporin products are immunosuppressants, but they also help in increasing natural tears. Varenicline is the only product that's not a topical product, and it's a nasal cholinergic agonist that helps increase the production of basal tear film. And then perfluorohexooctane is a semifluorinated alkane, which helps to create a monolayer on the interface of the tear film, which helps to reduce tear evaporation in the eye. So kind of interesting how they all work a little differently. And again, as I mentioned, most of them are topical, and those are given 2 to 4 times a day. Usually pretty well tolerated with just burning upon administration or maybe a little bit of eye blurriness associated as the most common adverse event. Okay, so then moving on to the systematic review, they're both from Cochrane. The first one looked at topical corticosteroids for dry eye, and they compared those to artificial tears. And looking at the OSDI index, they did find a change benefiting corticosteroids by a change of 0.29, which isn't probably clinically significant between the two groups. They also, however, looked at tear film breakup time, and it was longer with the steroids, which is beneficial compared to the artificial tears. And this difference was by 7 seconds, which the MCID is actually 5 seconds. So that was clinically significant. Greater reductions in patient-reported symptoms in those treated with steroids compared to cyclosporin were also noted. However, again, you can see the difference is really small and probably not clinically significant. The next review just looked at the topical cyclosporin products compared to artificial tears alone and then in combination with artificial tears. They did find that the combination of cyclosporin and artificial tears was slightly more effective than just the artificial tears alone at 6 months. However, this was based on just one study, and so the evidence is considered low quality. And then the evidence on tear production and stability was inconsistent. Then if we look at the guidelines, we just have a couple here. The first from the American Academy of Ophthalmology, and they looked at the treatment of dry eye, and they do recommend, as I'd mentioned before, artificial tears as a first-line treatment option. The prescription products are recommended as a second-line option. However, there's no preference of one or the other cited in the guideline. And then NICE also looked at cyclosporin for the treatment of dry eye, and they do recommend it as an option for those patients that have tried artificial tears and have not found a benefit. Now we're going to look at a few randomized clinical trials. We usually don't include placebo-controlled trials if there's good systematic reviews available. However, in this case, there weren't that many, so we're going to go over a couple of the noteworthy trials here very quickly. They're all vehicle-controlled or placebo-controlled trials, however. So the first one looked at water-free cyclosporin. This is a little bit different formulation in that the cyclosporin is not water soluble. So this water-free formulation is thought to help it to pass through the eye surface a little more effectively, perhaps causing it to work quicker and cause less blurriness. But anyway, so it was compared to a vehicle twice daily in patients with moderate to severe dry eye. The primary outcome was the corneal fluorescent staining score, as well as the VAS. So we looked at the ocular damage compared to kind of the symptom score, or how much their symptoms improved there. So looking at the results, we see that the use of cyclosporin was more effective than the vehicle by improving the TCFS, and then at the dryness score, that was not statistically significant in this case for those improvements. Looking at the next study, this is the OPUS 3 study. This is the first of 3 studies looking at lifitegrast in the OPUS study trial group, and they looked at patients with moderate to severe dry eye with baseline VAS scores greater than 40. Their primary endpoint being a change in eye dryness based on the VAS score, and they did find that the use of lifitegrast was more effective than placebo, both statistically and clinically significant. The next slide has the next 2 OPUS trials. Again, looking at lifitegrast in patients with severe to moderate dry eye. We did see that these patients had changes in the baseline. This was the interior corneal staining score, but that was improved significantly over placebo or the vehicle. And then, however, the OSDI score that I was referenced before, it was not changed significantly from the vehicle, but the exact numbers were not published. And then the last OPUS study, again, comparing real similar in design, comparing lifitegrast to the vehicle, looking at the changes in VAS as well as the staining scores. And they did find in this study that the symptoms were actually improved more significantly compared to the vehicle, which was clinically and statistically significant. However, those staining scores, were not statistically different from the vehicle preparation. The next 2 studies look at perfluoro hexyloctane, and they looked at people that had more severe dry eyes in both of these studies. Their baseline VAS were both over 60, and they were looking for their primary outcomes. We're looking at, again, changes in staining scores as well as VAS, and they did find that perfluorohexyloctane was more clinically and significantly better than the saline preparation for both the staining scores as well as the dryness scores. In that second study, again, is real similar design with perfluoroxyhexane or hexyloctane, and they found in this study, again, same primary outcome, that it was statistically superior to the saline and staining scores, but this really didn't meet the minimal clinically significant threshold. And then the dryness score, again, was improved statistically and clinically significant as well. And then the last study looked at varenicline, two different concentrations. The 0.03 milligram is the approved dose, one spray given twice daily. And they studied this in adult patients, and they looked at the STS, or the Schirmer test score, which measures tear volume. And so the primary outcome was the percentage of patients achieving a 10 millimeter improvement or more in the STS. And this is what's considered clinically meaningful. And they did find that both of the preparations were superior to vehicle, with number needed to treat of 5 for both strengths. Now moving on to the prior authorization criteria. Again, we want to allow a pathway for coverage for both dry eye and the VK diagnoses when they're funded in 2027, or allow case-by-case review for those with the under the EPSDD program. Or lastly, two, we want to consider those people that might have comorbidities that would qualify for coverage. And again, the over-the-counter artificial tear preparations do not require prior authorization. So number one, we ask the diagnosis. Number two, if it's an FDA-approved indication. Number three, we ask if it's a dry eye product or one for VK. If it's a renewal, then ask them to go to the renewal criteria. Number four, we're looking at patients with dry eye. If so, we ask if the diagnosis is funded. If it is, go to 8, but if not, asking again about those comorbidities. So if they have dry eye resulting in blurred vision or other impairments that are the result of chronic eye conditions or medical conditions such as Sjogren's syndrome, lupus, cataracts, arthritis, something like that, that predisposes them to dry eye. If yes, go to 8. If not, go to 7. Here we address the EPSD population. Again, if they qualify under that, then we ask that they go to 8. And then here is just asking if the patient's tried artificial tears or lubricants for at least 4 weeks without symptom improvement, since that is a first-line go-to therapy. If yes, asking just a documentation of those dry eye symptoms, so we can look at that in the renewal criteria. And then number 10 here, we address the VK population, just asking if the diagnosis is funded. In number 11 and number 12, again, asking if this patient's eligible due to EPSDD coverage. If yes, go to 13, just asking that the medication is being prescribed by an optometrist or ophthalmologist, just because this is such a rare condition that it really should be diagnosed by a specialist. And then if yes, then we're asking number 14, just that the provider try a preferred product. And if not, then it would still be approved. Looking at the renewal criteria, just again, asking if it's for a previously approved dry eye medication. If yes, and the patient has dry eye, just asking them to record an improvement in symptoms. So is there documentation of improvement from baseline dry eye symptom scores based on the OSDI, a change of 4.5 units or more, or the VAS, which would be a reduction of 30% or more, which was seen in all the trials that we just reviewed. They had, if they were statistically significant, all those patients did have reductions of 30% or more. And if so, then improve it for 12 months. Then the last question, number 4, relates to the VK population. They don't have as many validated measurements because it is so rare. So just asking that the patient has seen improvement in symptoms. If so, then again, it would be approved for the maximum of 12 months. So our recommendations for the class are to create a PDL class for prescription drugs used for dry eye and make all those prescription products for dry eye as well as VK as non-preferred based on the evidence. And then no change again in the coverage of the OTC artificial tear products. And then implement a PA criteria to provide that pathway for coverage for VK as well for dry eye for those patients with comorbidities that allow funding or for those that qualify for the EPSTD, under EPSTD. And then evaluate costs in executive session. I'm happy to take any questions. I don't think we have any public comment on this class.
We do not. Good job, Kathy. Any questions for Kathy?
I move for approval.
Appreciate it, Doug.
Do we have a second?
Second.
Thanks, Eddie.
All right, all those in favor?
Aye.
Aye. Aye.
Anyone opposed? Abstain? All right, thank you all.
All right. Next, draw your attention to page 104 if you're following along in the packet, and we have a Spravato PA update. Turn it over to Sarah Servant.
Thank you. And so this is a combination of a PA update for Spravato, which just got a new indication for monotherapy in patients with treatment-resistant depression. So that's one of the reasons why we're bringing this back. And we're doing it in conjunction with a utilization review of our current Spravato utilization for the Medicaid population. So the background here, Spravato does have a few kind of different nuanced indications for the same population. It's used to treat treatment-resistant depression, and it's approved now in conjunction with an antidepressant as monotherapy for that population, or for people with major depressive disorder that have acute suicidal ideation or behavior in conjunction with an antidepressant. It does have some common side effects, including disassociation, respiratory depression. It's got some risk for abuse and misuse, as well as like impaired ability to drive and cognitive impairment. Because of some of these side effects, it does have a REMS program that is intended to monitor and manage these. It is given in the clinic, so within a provided clinic with at least 2 hours of monitoring after administration. Dosing is twice weekly for the first month, and then the doses decrease to weekly or every other week, depending on the patient's symptoms. For Oregon Medicaid, it can be bought either by the clinic that's administering it, or it can be billed by a pharmacy who then delivers it to the clinic. The patient can't come into a pharmacy and pick it up. But when it is billed through a pharmacy, fee-for-service is the payer for Oregon Medicaid. For members that are in a CCO, they would be responsible for covering medical claims if the clinic is buying the drug and administering it themselves. But the majority of our utilization in Oregon Medicaid goes through the fee-for-service benefit and is billed by a pharmacy. We do in fee-for-service, we do require a PA to confirm diagnosis of treatment-resistant depression, verify that they are currently on an oral antidepressant, verify dose, and then document benefit after the first month. The definition of treatment-resistant depression that was used in clinical trials of esketamine was lack of benefit with at least 2 antidepressants that were used with an adequate dose and duration for the current depressive episode. There are a lot of recommendations out there and options for first-line treatment of depression, and these include SSRIs, SNRIs, bupropion, and mirtazapine. Recommendations that are put out by the Mental Health Clinical Advisory Group, as well as other organizations, suggest switching to another first-line agent from either the same or a different class if the first drug that a patient tries doesn't work, or if they have side effects to that first drug. You can also augment current therapy with a second agent, and drugs that have some benefit, evidence of benefit as augmentation therapy are listed on this slide. They include esketamine, but also second-generation antipsychotics, bupropion and mirtazapine as our antidepressants, lithium and modafinil. So the new evidence that we reviewed with this PA update was a randomized control trial, phase 3 double-blind trial that was unpublished at the time that we did this review, but it enrolled people with moderate to severe depression symptoms who had treatment-resistant depression without psychotic features, symptoms of depression for more than 2 years, and had failed to respond to at least 2 different antidepressants. They did exclude people who had tried some of the more invasive or last line treatments for depression, including ECT, deep brain stimulation, or vagal nerve stimulation. They also excluded people with a history of seizures. And you can see here, these are unpublished results, but for esketamine, they studied the 2 different maintenance doses, 56 milligrams or 84 milligrams compared to placebo. The number of people that were analyzed in the unpublished data were not the number of people randomized, and it's not super clear at this point what population was analyzed because we don't have that published data. But they did document change in the primary endpoint, which was the MADRS score at 28 days with esketamine compared to placebo, with a difference compared to placebo of about 5 or 6 to 7 points on that MADRS score. Some of the safety adverse effects that were observed in this trial were very similar to the other randomized control trials of esketamine. The common side effects are reported here and include dissociation, nausea, dizziness, headache, anxiety, vomiting, feeling drunk, and then that sedation as well. Limitations, again, this was an unpublished study, so risk of bias cannot be fully assessed. There is potential for unblinding because of some of these side effects that were more common with treatment. That is difficult to control for in these randomized control trials, but it does increase risk of bias. And then again, there was no details available on how the missing data was handled between the number of people randomized and how many people were in that initial analysis. And hopefully when this study gets published, we'll get some of those details. And then shifting over to look at Medicaid utilization, the goals of this analysis were to look and see if we could identify diagnosis of treatment-resistant depression based on claims for people who were requesting treatment for esketamine, and then evaluate how many people continued treatment beyond that 1-month induction period. So for that first population, we looked at prior antidepressants in people who had a paid or denied claim for esketamine. And for that second question, we looked at continuation of therapy for people with paid claims for esketamine. And the period that we were looking for utilization was since 2019, which was when esketamine, we first saw claims for esketamine. So this is almost a 5-year window. So overall, we identified 229 people with claims for esketamine, and about 61% of these members had more claims for more than 2 antidepressants in the prior 12 months. But when we looked at people who had 2 antidepressants with an adequate dose and duration to indicate they had tried an antidepressant long enough to see efficacy with that medication, that number dropped to 29% of members. In members who had an initial denial, 74% had a subsequent paid claim in the following 3 months, indicating that the provider did document treatment-resistant depression or acute suicidal ideation in the chart notes when they submitted a PA request. And then when looking at duration of therapy, about 73% of members who started esketamine had paid claims beyond 45 days, indicating that they probably stayed on therapy beyond that first 1 month induction period. About 18% of people had paid claims for less than 45 days, and the average was about 18, and they didn't have any subsequent denied claims. So that might indicate that they had voluntarily stopped taking esketamine. And then the remainder, about 10%, had less than 45 days of therapy and had a subsequent denied claim. And then about 13 of these members, 13 of the 22 members, had subsequently approved PAs. We did discuss this information with MCAG, and just as a reminder, the Mental Health Clinical Advisory Group is advisory to this committee, the P&T Committee. They have 18 members who have a lot of practical experience across the realm of mental health treatments. They had a pretty lengthy discussion about what level of documentation should be required to verify treatment-resistant depression. We specifically asked them to look at this question because of the information that we get on PA requests is sometimes difficult to determine or evaluate. And sometimes we get conflicting data between claims and chart notes. So the points that they had talked about, they looked at the evidence for esketamine, the utilization that I've also presented here for you today. They discussed the lived experiences of people with depression, other guideline recommendations, and then overall treatment success rate after people have tried at least 2 antidepressants. And as you all probably know, after people have tried at least 2 and not have benefit, the chances, the statistical chances of them responding to another agent are fairly low. And they recommended, based on all of those points in discussion, to incorporate intolerance to oral antidepressants and provider attestation of previous antidepressant trials into our PA criteria when we're considering whether the patient actually has a diagnosis of treatment-resistant depression. And so here is the PA criteria with those recommendations incorporated. Question number 6 is just an update to align with that new indication of monotherapy for treatment-resistant depression. So no longer requiring documentation of a oral antidepressant, current use of an oral antidepressant. So we're recommending removing that question. And then modifying that definition for treatment-resistant depression to include prescriber attestation, and then as well as intolerance to at least 2 antidepressants. And then questions 7 through 9 remain the same, so no changes to these questions here. But then similarly in the renewal criteria, just removing that question that in order to align with that new indication of monotherapy. So the recommendations overall are to update the PA criteria to permit monotherapy, then clarify the documentation required to support that diagnosis of treatment-resistant depression. And I'd be happy to take questions if people have them.
This is not a question, but I think this clarification of the previous trials absolutely makes sense. I mean, if somebody tried, fluoxetine 15 years ago and, had an allergic reaction to it, or, it caused them to have intolerable anxiety or whatever, right? There's no reason for us to make them try that again. So, I mean, I think, these updates make sense, and I'm still skeptical of esketamine in general, but as far as the, FDA approval and creating a pathway for monotherapy, I think these are reasonable.
Hey, Sarah, I have a question, although it may be kind of a moot point with the addition of the provider attestation. But what, for the evaluation that you guys did, how did you define adequate dose and duration?
Yeah, so we were looking at people who had claims for at least 6 weeks, and then dose was defined based on the drug. And so we were using doses that are like recommended by MCAG or in the FDA labeling is how we set those thresholds. Yeah, but I think our data does show that we cannot really identify accurately what meds people have been on previously. Yeah.
Yeah, no, this totally makes sense. But yeah, so as I said, may not be relevant, but I know that that's sometimes a challenge. So just wondered if you guys had figured out like the magic way to look at that. So
No, it seems like our chart notes from our providers are probably more accurate than our claims.
yes, yeah, no, totally agree with that.
Other questions for Sarah? We do have one industry representative that signed up to provide public comment, but we'll hold that until your questions are satisfied. Okay, with that, we have Adrian Lau. I've made you a co-host. Are you able to unmute your line?
Hello, can you guys hear me okay?
You bet. Hear you loud and clear, and the floor is yours for up to 3 minutes.
All right, thank you. Yeah, good afternoon. So my name is Adrian Lau. I am part of the Value and Evidence Scientific Engagement team at Johnson & Johnson Innovative Medicine. And thank you for this opportunity to speak to you about Spravato esketamine nasal spray. Spravato is an NMDA receptor antagonist indicated for the treatment of treatment-resistant depression, TRD, in adults as monotherapy or in conjunction with an oral antidepressant, and depressive symptoms in adults with major depressive disorder, MDD, with acute suicidal ideation or behavior in conjunction with an oral antidepressant. Spravato has a boxed warning for sedation, dissociation, respiratory depression, abuse and misuse, and suicidal thoughts and behaviors, and is only available through a restricted program called Spravato REMS. We note that the recommended prior authorization criteria does not allow for the use of Spravato in those age 65 or older. Of the total number of patients in randomized double-blind placebo-controlled short-term clinical studies exposed to Spravato, 12% were 65 years and older, and 1% were 75 years and older. No overall differences in the safety profile were observed between patients 65 years and older and patients younger than 65 years. In a phase 3 short-term flexible dosed clinical trial in elderly patients at least 65 years with TRD, the Spravato plus oral antidepressant group demonstrated a clinically meaningful but not statistically significant improvement in the MADRS total score from baseline to day 28 compared to the oral antidepressant plus placebo nasal spray group. Primary endpoint minus 10.0 versus minus 6.3. Least squares mean difference, median unbiased estimate minus 3.6. P-value is 0.059. Doses used in this trial were lower compared with doses used in other esketamine trials of patients aged 18 through 64 years. The initial dose of Spravato in elderly patients was 28 milligrams to facilitate improved tolerability. Investigators increasingly used higher doses during the later portion of the study. The most common treatment emergent adverse events in the Spravato plus oral antidepressant group were dizziness, nausea, a generally transient elevation in blood pressure, fatigue, headache, and dissociation. In summary, Spravato monotherapy has demonstrated efficacy and safety in the treatment of TRD when compared to placebo. Additionally, please consider allowing coverage for patients over 65 years. Thank you.
Thank you, Adrian. Any questions from the committee for Adrian? All right, and again, thank you. Hearing none, the recommendations are back on the screen in front of you. Update the PA criteria as proposed to permit the monotherapy. and to clarify the documentation required to support that diagnosis of treatment-resistant depression.
Hey, Roger, I have one quick question before we
Please.
vote. And I'm trying to remember back to when we originally reviewed this and the age limitation, but it wasn't, so remind me, the excluding 65 and older wasn't necessarily based on a clinical recommendation, correct? It was just based on the fact that when they're 65 and older, typically we wouldn't be covering them. Am I remembering that right? Or am I making that up completely?
So this was based on the study that was done in people 65 and older, and it was added to the criteria because the Spravato did not differentiate from placebo in that study.
Got it.
Yeah.
Was that out of the VA?
I think it was an industry-sponsored study, but I'm not positive.
Okay. Because, all right. Yeah, no, that's totally fine. I couldn't decide if I was remembering that correctly. So thank you.
But you are correct, in fact, that patient population would predominantly be covered under Medicare. Okay, so again, recommendation to update the PA criteria to clarify the documentation required for the diagnosis of treatment-resistant depression and permit monotherapy with esketamine. Any other questions or motion to approve?
Motion to approve.
Second.
Thanks,
All right.
Rosnetti.
Yep. All those in favor?
Aye.
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 Opposed? Abstain? All right. Thank you.
We are well ahead of schedule. I think we should still take our break at this time. The next topic does have a couple people that wanted to provide public comment. I haven't seen them both enter the panel yet. So I think out of respect to get closer to the regular time, let's take a 15-minute break. I will get my timer going and then we'll reconvene and continue with the agenda. So thank you all and bear with me for a moment while I get my timer up. All right, welcome back from break. Going to quickly look and make sure. I know a few people left and have rejoined the meeting, so I'm checking to make sure that I've got all of the committee members flagged as hosts. So give me just a minute, please. Great, it looks like we've got everybody back. So again, if you're following along on the packet of materials posted to our website, we're going to continue on page 136 of the packet. We have the new drug evaluation for suzetrigine and turn it over to Sarah Fletcher.
Thanks, Roger. Yes, the drug that we're going to be talking about next is suzetrigine or Journavx. If you go to the next slide. This is a new drug evaluation for a first new non-narcotic pain medication that's been approved in a really long time. So it's approved for the treatment of moderate to severe acute pain in adults. It entered the market this year. Use beyond 14 days has not been studied, and that is in the package labeling. And I'll go in the data to show you the use beyond 48 hours and the use up to 14 days. It works by inhibiting a specific sodium channel that's used to prevent pain signals to the brain and spinal cord. Now, this happens peripherally, and it is not expected to be addictive, and it does not have a controlled substance marker. It's not a C2 or a C3 or anything like that. If you can go to the next slide. The approval was based off of primarily 2 phase 3 double-blind or double-blind, randomized, multicenter, active, and placebo-controlled studies. One was done in patients who had moderate to severe post-surgical pain after a bunionectomy, and the other was after abdominoplasty. And the duration of treatment was up to 48 hours. Additionally, there is a single-arm study that I'll briefly talk about that does have a duration of treatment up to 14 days in patients who are surgical or non-surgical and have acute pain. If you go to the next slide. The two main studies were the Navigate 1 and Navigate 2. You see at the top, Navigate 1 was the bunionectomy study, and there were 3 drug treatment arms in these studies, randomized 2-1-2. So it was suzetrigine, 100 milligrams, then 50 every 12 hours. There's no titration. It did have a dummy placebo, so that it looked like it was being given every 6 hours, placebo every 6 hours, and then a low-dose hydrocodone, 325 every 6 hours. And I just want to call out that in studies that are 2 weeks or less, if you have attrition of more than 10%, that's pretty significantly high. And this was a 48-hour study with attrition of more than 10% in almost every group. And most of it was due to perceived lack of efficacy. Demographically, you can see that these were primarily younger patients in their 40s, mostly white, very much mostly women, especially in the abdominoplasty study. It was 98%. And they had a mean NPRS, or numeric pain rating scale, of about 7. And 7 and higher is considered severe, 4 to 6 is considered moderate. And as I mentioned earlier, this is a 48-hour trial or duration of treatment. So the next slide, it goes over the different inclusion and exclusion criteria. So these were adults. They had moderate to severe pain post-procedure. In the bunionectomy trial, they did have a regional block, and it was assessed within about 9 hours of the removal of the popliteal sciatic block. In the abdominoplasty trial, the patients were assessed for pain within 4 hours of the end of general anesthesia. And then you can see the other inclusion and exclusion criteria in the remainder of this slide. If you go to the next slide, the efficacy of this was based off of the time-weighted sum of pain intensity difference from hours 0 to 48, or the SPID 48. And that is an endpoint that the FDA does recommend in their draft non-binding pain assessment that they published for new pain drugs that may come on the market. However, there's not a specific MCID that I can find for this endpoint. It has been used in other studies. It's been used for drugs like Toradol when they've come onto the market. A higher score indicates more pain relief. A positive score does indicate pain relief. So the higher it gets, the better the number. And you can see in that first line, the suzetrigine versus placebo versus hydrocodone, and placebo was the lowest in all of them. The primary outcome was the least mean squared difference versus placebo, and suzetrigine was statistically significantly superior to placebo in both of the studies. And then the first key secondary outcome was versus the low-dose hydrocodone. And in the bunionectomy study, it is not superior. The confidence interval appears that the hydrocodone is actually better. In the Navigate 2 study, or abdominoplasty, there's no statistical difference in this superiority comparison. That same draft guidance recommended superiority-only comparisons and not non-inferiority, because there are so many other factors with pain that a non-inferiority comparison could have 2 drugs that are not actually working for pain. And then if you go to the next slide, there were additional secondary endpoints. Because of the hierarchical design of the study, all additional secondary endpoints are considered exploratory because it didn't meet that first key secondary endpoint. So this one was the median time to meaningful pain relief, which was a 2-point or higher change in the NPRS scale, and that is clinically significant. And you can see versus placebo, it is statistically different. The comparison was not done versus hydrocodone. And then all patients were allowed to have rescue medication use of 400 milligrams every 6 hours of ibuprofen, ideally at least 90 minutes after the first dose of pain med once they were first assessed for pain. And that was pretty similar between all of the groups. As far as overall use, the median use for the bunionectomy patients was about 800 milligrams for suzetrigine or placebo and 400 for the hydrocodone group. So a little bit less for hydrocodone. And then the abdominoplasty study, the median use was 800 milligrams in suzetrigine or hydrocodone, so pretty similar, and then a little higher in the placebo group at 1,200 milligrams. If you go to the next slide on safety, overall, there were not a lot of significant serious adverse events, and discontinuations due to adverse events were pretty low, and most of them were unlikely due to the medication. As I mentioned earlier, the attrition was mostly due to perceived lack of effect. Those serious adverse events you see in the Navigate 2 study were, I think, all assumed to not be due to the medication itself. There is a difference in nausea and vomiting when you compare suzetrigine versus hydrocodone, and it's statistically significant. I calculated a number needed to benefit of about 7 to 11 patients to prevent 1 episode of nausea or vomiting based off of the differences between those groups. If you go to the next slide, This is in the package labeling. So overall adverse events that occurred in more than 1% of patients, but also greater than placebo. So pruritus, which was still highest in the hydrocodone group, muscle spasms, increased CPK, and rash. And this was in primarily the 48-hour treatment duration. Overall, most common side effects were nausea, constipation, headache, but a lot of these were actually less than placebo. You can go to the next slide. Based on some of the labeling, concomitant use with a strong CYP3A inhibitor is not recommended. Strong inhibitors are ketoconazole, clarithromycin. There are some moderate inhibitors to be aware of. And then suzetrigine is actually a CYP3A inducer. Short-term use with an inducer, usually it takes a few weeks to actually get that induction. So for the short-term use, this is not something we need to think about too much. But if additional labeling comes in the future, some drugs like ticagrelor or CGRP inhibitors may have to be something that we think about when using this if there are future indications that are for longer use. And then patients who are taking hormonal contraceptives with a progestin that is not levonorgestrel or norethindrone have to use a backup method for the duration of treatment and for 28 days. And so that would include Depo-Provera. There's no black box warnings and there's no REMS program. If you go to the next slide, I just briefly want to touch on that single arm study where we have some evidence of use beyond 48 hours. This was a single arm study in moderate to severe pain. It included surgical and non-surgical patients, about 250 patients. It had the same dosing as we saw before and use up to 14 hours. Demographics were pretty similar, and I just want to call out that most of the patients in this were still surgical patients, 86.7%. And the patients were being admitted for things that were not expected to last very long. They weren't for multi-day admissions. They were anticipated to be in the hospital less than 48 hours from onset or from appearance. If you go to the next slide, I'm only including the rescue use and the safety on this because it is a single arm study, but the surgical patients, 80% did use concomitant ibuprofen and acetaminophen in addition to suzetrigine. If you look at just ibuprofen or acetaminophen and not both together, it's a little bit higher still. There was a pretty big difference in that between the surgical and non-surgical patients, but that non-surgical group is so small, it's hard to draw a conclusion. And then if you go to the next slide, it highlights the duration of treatment. And so you can see that those who discontinued because the pain had resolved in less than 14 days was 105 patients. And those who completed the whole 14 days was 53.5% of this study. Mean exposure was 9.8 days. So this is our evidence beyond 48 hours of use. And you can also see that the discontinuations due to lack of efficacy were much lower, 1.6%, than what we saw in those randomized trials where patients could have been taking a placebo. And then otherwise, the overall adverse events were pretty similar to what was seen in the randomized studies. So you go to the next slide. This is an exciting new agent in that we haven't had any new non-narcotic pain medications enter the market in a long time, but it's very new. There are still some limitations in what we know about it. Comparative efficacy beyond 48 hours is not really known. It was not superior to low-dose hydrocodone, and the difference was more defined in the bunionectomy study. And it's unclear if you're going to get a decrease in opioid prescribing because you can titrate opioids, and there was a lot of attrition due to perceived lack of effect. There's no clear clinically important difference on how to interpret that SPID 48 endpoint. And there was, as I mentioned, a large amount of attrition between the groups. And there was a very complicated imputation strategy for how to deal with that missing data. Most of the patients were female, 45 years old, and the surgical types may not be that representative of some of the Medicaid population. And because of the age, fewer comorbidities in these patients who are taking this medication. There were a lot of post-hoc analyses in these studies. I think it was 4 or 6, and that can lead to some reporting bias. And then some areas where we'd love to see data are beyond 14 days and randomized comparative data beyond 48 hours. We don't have data for chronic pain yet, and neuropathic pain is in a phase 3 study right now. We don't know anything about if someone were to use it with opioids. That's not the idea. We want to use less opioids, but we don't have any information on that as well. And then use with more significant acute pain surgeries like knee replacements, hip replacements, pancreatitis, kidney stones. Those generally elicit more pain than what's been studied so far in the current data that we have. And a good niche for this where we'd want to think about it, some of the history of substance abuse or contraindications to opioids, though we haven't looked at that specifically. So I just wanted to mention those. I am excited about this new drug, but we do want some new additional data. If we can go to the next slide. I'm going to show you the whole PA, but I'm just summarizing it here because I know those PAs get pretty wordy. It's a prior authorization right now for use beyond 48 hours. It's limited to adults with acute, moderate, severe pain that's documented by pain score. and then a maximum of 14 days per acute pain event. And then we do ask that there be inadequate relief or contraindications to the other non-narcotic pain medications where we have a lot more history of effectiveness and safety. And so if you'll go to the next slide, we'll just go page by page on the PA. You can see the authorizations for up to 14 days. It kicks in after 5 tablets, so that 100 milligram dose and then 50 Q12. Next slide. We ask if the patient's over 18 years old, if it's for acute pain, which we define as less than 30 days, and that's off of that FDA guidance for studying acute pain medications. Is it documented to be moderate to severe using some of the very common scales like the visual analog scale or the numeric pain rating scale? And then next page, have they already received 14 days for this particular indication? And is there documentation of inadequate relief or contraindication to acetaminophen and an NSAID? And so if you go to the next slide, our recommendation is to implement the prior authorization as proposed, which includes 48-hour use beyond 48 hours and limits to no more than 14 days. And I'd like to open it up to the committee members for questions before we go to public comment.
Hey, Sarah, just to clarify, so it won't need a PA for those 5 tablets?
Correct.
Okay, perfect.
Yeah. But if you're filling it beyond 5 tablets, whether that's before or after the surgery, it would require a PA.
Yep, got it. Okay.
And I'm so
Good job,
sorry.
Sarah.
Oh,
Please go ahead.
oh, I'm sure you mentioned it, but there's no contraindication for like a CKD.
No, it actually, it's pretty well split between renal and hepatic clearance. There is a dose adjustment for, I think, significant hepatic or moderate hepatic insufficiency, but I don't think there's a renal adjustment or renal warnings that I remember.
Okay, thank you.
Good questions. Other questions for Sarah? All right, hearing none, we do have a representative from Vertex, Chad Duncan. Chad, are you able to unmute your line?
Yes, I am. Can you hear me?
Hear you loud and clear, and the floor is yours.
Thank you. My name's Chad Duncan. I'm a PharmD with Vertex Pharmaceuticals on the field health economics and outcomes research team. And thank you for the opportunity to provide public testimony today. And contraindications, a complete list of warnings, precautions, and adverse reactions associated with Journavx have been previously shared and can be found in the Journavx prescribing information. And thank you, Dr. Fletcher, for your excellent review on the pivotal trials of Journavx. Acute pain is sudden in onset with postoperative acute pain or other trauma that usually peaks within that 2 to 3 days or that 48 to 72 hour time frame after that injury and or surgery, and may last up to 90 days in total. And so we have looked at patients that up to 2/3 of patients do discontinue that treatment within 30 days. And the average duration of a prescription filled for acute pain here in the US is about 12 days, but the course of therapy may be shorter or longer, depending on the need and procedure type. I think one thing that hasn't been talked about is really the opioid crisis that we have here in the US. And according to the Kaiser Family Foundation analysis, approximately 3% of all Medicaid beneficiaries have a diagnosis of OUD. And furthermore, compared to commercially insured beneficiaries, previously opioid naive Medicaid beneficiaries almost 3.8 times more likely to experience an overdose after being prescribed an opioid. In another analysis of opioid naive patients who receive prescription opioids for the management of acute pain here in the US, the 1, 2, and 3 year incident rates for OUD among acute pain users with prescription opioids in the Medicaid population is 3.13% in year 1, 4.5% in year 2, and 5.6% in year 3. In contrast to opioids, Journavx is a selective blocker of the NAV or sodium channel 1.8 and is not expected to interact with opioid receptors based on the available data, including this mechanism of action, the preclinical data, and the clinical adverse event data as well. Dr. Fletcher did talk about the open label single arm study that was there with 256 patients. And the average duration there was between 9 and 10 days for patients in a study that was that the primary endpoint really was to look at safety, but it was for patients to be able to use the pain medication of Journavx up to 14 days or until their pain resolved. And we see that that's right at almost between 9 and 10 days total. And from that, only 2% discontinued due to AEs and only 1.6% due to the lack of efficacy. and over 83% of the patients reported either good, very good, or excellent on the patient global assessment at the end of their treatment. The Vertex budget impact model model suggests that Genavix will have a limited budget impact in the first 2 years on formulary, given the projected reductions in the OUD and opioid abuse costs, as well as adverse events such as nausea and vomiting that have been mentioned already. And we do ask that there is a PA that would allow a quantity limit of 29 tablets per 14 days instead of the current 5 tablets or 48 hours in 30 days.
Thank you, Chad. Any questions for Chad from the committee? All right, appreciate your time. We also had a member of the public, Mary Rebar, that signed up to provide public comment. Are you able to unmute your line?
Yes, I am.
Great. You are not a representative of, excuse me, pardon me for 1 minute. Get this. You are not a member of industry, and it says you weren't asked here to be by advocacy. I just for the committee's sake wanted to find out if you have any conflicts of interest. So if you could say how you heard about this meeting and if you have any conflicts.
I heard about it when I was at the Oregon State Capitol on Rare Disease Day.
Fantastic. Well, with that, you have 3 minutes to address the committee. So the floor is yours.
Thank you. Thank you for the opportunity to address my concerns today with the panel. My name is Mary Rebar, and I'm a caregiver and a resident of Benton County. Have you ever had a loved one that experienced excruciating pain post-surgery? My mother has 1 kidney. Thus, she cannot take opioids for post-surgical pain, limiting her options for pain relief. 2 items to call to your attention. A 2-day post-surgery medication is not realistic for patients nor caregivers. As a caregiver, the day of discharge from the hospital, I traveled to the pharmacy 3 times, attempting to receive the pain meds. I waited for over 2 hours in line to receive the post-surgery medication. That did not count my 1.5 hours of drive times to make 3 trips into town. I had a Metro person suggest I change pharmacies. I laughed out loud, for there are no options of other pharmacies in her small town. I replied that would add 10 miles of drive time. Second, please remember Oregon is rural. A 2-day window of post-surgery medication would be designed for a metro area. Having to wait on prior authorization is challenging for both the caregiver and the patient. I do not want a patient or caregiver to make a tough choice or a less safe choice of reaching for outdated medication or expired medication to relieve pain. Please better serve all Oregonians, no matter where they live. Please note, for rare diseases and other acute conditions, having an option of a non-opioid for moderate or acute pain post-surgery is a dream come true. Please make it accessible to all people living in Oregon by removing the barriers in rural areas and allowing physicians to make the decision to prescribe the longer period of time. Thank you.
Thank you, Mary. I appreciate you showing up and sharing your thoughts. Any questions from the committee for Mary?
Well, I have a comment, and I agree with Mary that the manufacturer needs to do some studies to demonstrate the effectiveness beyond 48 hours and without added ibuprofen and Tylenol. It's you know, the studies that were done to get FDA approval were the minimal amount. It was fairly unimpressive. What's impressive about it is it's a new drug type. What isn't very impressive were the types of studies that were done to get approval. There's a lot that we don't know about it, and it doesn't look to be much more effective than what we have right now.
Appreciate your comments, Doug. Anybody else have any questions or comments? All right. Recommendations are back in front of you on the board. Recommendation is to implement proposed PA criteria for use beyond 48 hours and to limit the use to no more than 14 days.
I move for adoption of these guidelines.
Second.
All right.
Thanks.
All those in favor?
Aye.
Aye.
Anyone? Oh, sorry. Anyone opposed? Abstain? All right. Thank you all.
Great. Thank you. Following in the packet, we draw your attention to page 148. And Dave Ingen, we'll turn it over to you.
Right. Thank you. Yeah, today we'll review drugs to treat molluscum contagiosum. I'll abbreviate that for MC for today. Next slide. Yeah, we'll briefly examine the therapies for MC, noting that the condition is not currently funded based on the HERC's list of prioritized health services. We'll propose some PA criteria, and we'll mainly to allow for coverage through EPSDT for eligible patients. Yeah, so MC, it's a common, highly contagious but benign viral skin infection. It's characterized mostly relatively small flesh-colored raised papules, and typically on the trunk, axilla, and extremities. Most of the cases of MC are self-limiting, and they'll resolve without treatment within generally 6 to 18 months. Less than 5% of children in the US experience MC, with the largest incidence in children between the ages of basically birth to 14 years old. Right. There's two FDA-approved treatments. One of them's cantharidin, and the other one's berdazimer. And both are approved for use in young children through adults. However, cantharidin is applied once every 3 weeks for 12 weeks, while berdazimer is applied once daily for up to 12 weeks. We did have a Cochrane review that evaluated therapies for MC, but it didn't include cantharidin and berdazimer. The primary outcome was complete clearance of MC lesions up to 3 months after the start of treatment. There was moderate quality evidence that imiquimod 5% topical cream resulted in short-term clinical cure rates that were similar to placebo, but higher rates of application site reactions, and low-quality evidence that showed imiquimod to be less effective for short-term cure rates compared to cryotherapy. And there was insufficient evidence to assess differences between other treatments or drugs used off-label to treat MC lesions. Let's look at the clinical trials briefly. For cantharidin, there were 2 similar phase 3 trials with cantharidin topical solution versus placebo. The groups generally balance between the sexes, and they included mostly younger patients, so that'd be under 11 years old with MC lesions. The main outcome that was assessed was proportion of patients who achieved complete clearance of all treatable and new molluscum lesions at week 12. And the investigators reported that a higher proportion of patients treated with cantharidin achieved clearance compared to placebo at 12 weeks. Mean difference was about 29% in the first trial and about 40% in the second trial. However, there's little known about the long-term efficacy and safety of cantharidin beyond 12 weeks. Let's look at berdazimer. There are 3 phase 3 trials with berdazimer gel versus placebo. The groups were once again generally balanced and also included mostly younger patients. The main outcome assessed was proportion of patients who achieved complete clearance of all treatable MC lesions at week 12. 2 of the trials did not demonstrate a statistically significant difference compared to placebo. But in the third, B simple 4, the investigators reported a higher proportion of patients with complete lesion clearance compared to placebo. As with cantharidin, there's little known about long-term efficacy and safety beyond 12 weeks. But both cantharidin and berdazimer were generally well tolerated. The adverse effects, you can look at it in the packet, but they were limited to mostly application site discomfort, including pain, erythema, and pruritus. So moving to the next page, just the recommendations were to create a new preferred drug list for agents to treat molluscum contagiosum, to add cantharidin topical solution and berdazimer gel to the molluscum contagiosum drugs PDL class, and then implement PA criteria for cantharidin and berdazimer to establish specific medical necessity and appropriateness criteria for members with the early periodic screening, diagnostic, and treatment benefit. We have some PA criteria that we want to propose. Once again, the goals are consistent with our recommendations. If you look on the next page, we've got both agents here, FDA approved, got their indications and basic dosing parameters. And getting into the criteria itself, it's pretty straightforward. Includes a funding question and then allows for EPSDT coverage review if appropriate. Then we do ask if they've waited an appropriate amount of time for natural resolution. And then we ask if they've had previous treatment of those lesions. And then number 7, make sure that a dermatologist has at least been consulted. And then 8 are just the baseline assessments, just to make sure that it's a condition that is necessary to be treated, especially in certain patients that it might be more problematic for them. So if we look at number 9, we just make sure that it's prescribed appropriately. There's information in the prescribing guide about how to appropriately administer that. And so number 10, we make sure there's not an issue with multiple treatments going on at once. And that's also part of the prescribing guide. It's not indicated to be used with multiple therapies. So yeah, any questions on either of those drugs?
Thanks, Dave. Any questions for Dave? We do not have anyone signed up for public comments, so we'll go back to the recommendations. Are we at that point, Dave?
Yes, that'd be great. Thank you.
So again, the recommendation is to create a new PDL class for the molluscum contagiosum treatments. Add the 2 agents to the class. and to implement this proposed PA criteria with that pathway for coverage for EPSDT now, which would naturally progress and transition in 27 for the broader population. Questions?
Roger, I guess I just have one question.
Yeah,
So
Stacy.
when it says that the PA criteria, one of the questions is about it being particularly troublesome, and that's defined as like painful or itching. But I'm thinking more about like psychologically troublesome. You know, a middle schooler who's, you know, are we asking what the troublesomeness is, I guess? Or do they just have to say, does the provider just have to say that the lesions are causing significant distress in the patient?
Yeah, the intent was to allow the prescriber to
Okay.
whether
Okay.
Yeah,
I think that would be interfering with the activities of daily living and meet the
Yes.
necessity under EPSDT.
Okay, perfect. That was my thought too, but I just, since we called out like pain and itching, like, did it have to be physically troublesome? But again, as long as we allow the prescriber to determine that, that's fine with me.
Great. Thank you.
Appreciate the question. Other questions for Dave? And or a motion to approve?
This is Jeannie. I'll motion to approve.
Thanks, Jeannie.
Do we have a second?
Second, Doug Carr.
Wonderful. Thanks, Doug. All right. All those in favor?
Aye. Aye.
Anyone opposed? Abstain. All right. Thank you all.
Great. Again, moving on in the packet, page 161 is the nutritional supplements PA update, and we'll turn it back over to Sarah Fletcher.
Thanks, Roger. So yes, we're going to talk about a nutritional supplements PA update. I anticipate this will be the first of probably more than one time that we may bring this here, but if you can go to the next slide. Nutritional supplements, as most of you know, are not regulated the same as the Food and Drug Administered approved medications. And so when I'm talking about nutritional supplement, those are vitamins, minerals, herbs, botanicals, amino acids, and other supplements that can increase daily dietary intake of certain substances and concentrates or metabolites and extracts. Because of that, they don't have the same kind of coding and status, and our ability to cover them is a little bit more limited. Some products do go through the FDA approval pathway, and they are truly considered a drug, like levocarnitine has some IV options that are truly considered a drug, but a lot of them aren't. And right now in the Oregon Health Plan, we do have a nutritional supplement PA that covers enteral and oral nutritional formula for members with certain conditions that are described in OAR 410, 148, 0260, and that's, you can see below in the table. But that one implicitly excludes oral dosage forms, things like tablets, capsules, drops. And usually that is appropriate. But in looking at some of the diseases that are covered, and specifically those inborn areas of metabolism, we've kind of identified that we may need to do some more work in this area. If you go to the next slide, in December, we looked at the urea cycle disorders and even the specific drugs for that for those disorders, so that patients need to be on a protein restriction and then take supplementation with arginine and citrulline in most cases. Now, there are some ways through a medical benefit to be able to obtain these, but we want to make it more clear on what we do intend to be able to cover. And in that situation, it's very important that we do have a pathway to coverage for patients with those particular conditions. We've identified a few others like carnitine deficiencies in patients who have primary disorders of carnitine metabolism or rare disorders of amino acid metabolism, where specific amino acids like glycine or ornithine may be appropriate, even though they're technically not drugs. And so if you can go to the next slide, right now the current policy, if a patient did truly need a product in this category, it could be obtained if they were an EPSDT beneficiary. So if the patient was 21 years or under, or sorry, was under 21 years. But those who are over 21 years who don't have an EPSDT benefit, they're just not covered under the state plan. And so this policy, as we're trying to outline it, proposes some requirements for what nutritional supplements can be available if there truly are no FDA-approved versions or an appropriate dose for an approved version based off of the conditions that we intend to have coverage for under the OAR 410-148-0260. So if you can go to the next slide. This is the initial form of this PA as we work on implementation, and it's to provide a pathway for these non-rebatable nutritional supplements and to limit it to certain diagnoses where there seems to be some sufficient evidence of benefit, knowing that these are very rare conditions that won't have our normal evidence pathway because they are so uncommon. And the ones that require PA, I have some coding numbers that aren't going to mean a lot, but those are things like arginine, citrulline, so that we have a way to adjudicate it. You can go to the next slide. I've got two tables. The bottom one you've already seen. Those are the conditions that OAR is specifically wanting to cover. The above one are some of the conditions, nutritional supplements and conditions that we've already identified that we do want to make a pathway for. And we also want to work on alignment within the medical benefit. And so by having it written out here, we can work on that as well. If you go to the next slide, we have written, is the patient an EPSDT member? If they're not right now, it's not covered. If the patient is an EPSDT benefit based off of this, if it's in one of those diagnoses and ICD-10 codes and nutritional supplements on that table 1 in the previous slide, we would find a way to get it covered for this particular patient. If it's not, but the patient has an inborn error of metabolism and is being prescribed by one of the specialists, then we would try to add it to the table. If it's not for an inborn error of metabolism, but it is for one of those other conditions, if you go to the next slide, so going to number 6, so one of those conditions in table 2 that's not an inborn error of metabolism, but maybe CF or something else, then we can continue to evaluate it based off of number 7, which is to have the opportunity to provide evidence for clinical benefit, and we could approve it for a month while trying to tease out the process, because some of these particular diseases, just short-term use of not being able to have these kinds of supplements can have some long-term effects. So as I mentioned, this is probably going to be a little bit of a process as we try to update it and figure out the implementation, but we wanted to start adding some clarification for how to make these accessible to patients. If you go to the recommendations, the next page, what we're asking is to implement the prior authorization coverage criteria so that we can clarify the current standards of care for those eligible for EPSDT, and then to have a recommendation to OHA to add coverage. And so if the committee makes that recommendation, then we can work on changing the what is actually covered for those patients who do not qualify for EPSDT. So are there any questions? This is a little bit outside our normal wheelhouse.
Good job, Sarah. Any questions for Sarah? No public comment. So the recommendations are again on the screen in front of you. We want to implement PA criteria to limit coverage for some specific nutritional supplements. Also add some coverage for some of those solid dosage forms, powders, concentrated liquids, with those members with inborn errors of metabolism. So additional questions or motion to approve the proposal?
This is Jeannie. I'll motion to approve.
Appreciate it, Jeannie.
Second.
Thanks, Eddie.
All right, all those in favor?
Aye.
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 Anyone opposed? Abstain? All right, thank you.
All right. Last topic of the day starts on page 167 if you're following in the packet of materials, and we'll turn it back over to Deanna Moretz.
Thanks, Roger. Yes, we are going to look at a drug called Nuedexta, which is a combination of dextromethorphan and quinidine, which was actually approved in 2010, but the indication for which the drug was approved has not been funded. So this is part of the benefit plan update that we've been looking at. So if we can go to the next slide. You are probably familiar. These are our 3 questions that we ask for all of our new drug reviews. Let's go on to the next slide. So we'll be talking about pseudobulbar affect, which is a neurologic condition characterized by involuntary outbursts of laughing or crying that is disproportionate to the patient's emotional state. It's associated with underlying neurodegenerative diseases such as stroke, TBI, Parkinson's disease, Alzheimer's, ALS, and MS. Pseudobulbar affect is thought to occur maybe because of injury or disease that is disrupting the pathways that regulate emotional expression, including the corticobulbar tracts and the basal ganglia. So in addition to the underlying disorder, PBA can also have an impact on well-being and social functioning because there could be some stigma attached to the loss of emotional control. So if we could go to the next slide, please. So as I mentioned, this is a combination of dextromethorphan 20 milligrams and quinidine 10 milligrams. They're not really sure why the dextromethorphan is effective in treating the pseudobulbar affect. The quinidine is very, very low dose, only 10 milligrams. The therapeutic dose is usually in the realm of 200 milligrams. And the reason that the quinidine was added is because it's a CYP2D6 inhibitor of dextromethorphan. So the quinidine just increases the bioavailability of the dextromethorphan. So as I mentioned, this was FDA approved for PBA in 2010. If we could go to the next slide. The American Academy of Neurology has issued some guidance. In 2009, they said that dextromethorphan combined with quinidine is probably effective for treatment of PBA in people with ALS, although the side effects might limit its usefulness. And this was a moderate recommendation based on high quality evidence. And then in 2014, they came out and said that new Dexa is possibly effective and safe and may be considered for treating individuals that have multiple sclerosis and PBA. And that's a weak recommendation based on moderate quality evidence. If we can go to the next slide. Before we talk about the clinical trial that led to the FDA approval, I just wanted to talk about what comparative endpoints they looked at. So the primary endpoint was the number of laughing or crying episodes per day as recorded in the patient's daily diary. And then they also looked at these three other outcomes as secondary endpoints. So the Center for Neurologic Study Lability, or CNSLS, that's a patient reported measure of their emotional status. The Beck Depression Inventory, and then the Neuropsychiatric Inventory. So all of these are either patient recorded or caregiver recorded questionnaires. So if we go to the next slide. So this was the clinical trial that led to the FDA approval. It was a 12-week double-blind, placebo-controlled, randomized controlled trial. Relatively small, a little over 300 patients. Most of the patients were white, and one of the inclusion criteria, I highlighted this, is they had to be adults. 18, that's a misprint. I think they were older than 18 years old of age. It's in the packet, but how old that they went to, but they focused on people that had that CNS-LS score greater than 13, and they had to either have MS or ALS along with the PBA symptoms to be enrolled in the study. If they had a major psychiatric disorder, they were excluded. And as I mentioned, the primary outcome was a change from baseline in the number of PBA episodes per day as over 3 months. And you see that the change was, they looked at the two different strengths of dextromethorphan, either 20 or 30 milligrams with the same amount of quinidine. The difference was about 1 PBA episode per day. That was considered statistically significant, but the clinical relevance of decreasing from, maybe a baseline of 5 episodes to 4, that's debatable. Next slide, please. So some of the trial limitations are this can only be applied to people that have PBA with ALS or MS. We can't apply this to people that have other reasons for having PBA, or if they have a CNS LS score that's less than 12. There was a substantial placebo effect on reducing the number of PBA episodes per day. And as I mentioned, although the results were statistically significant, the clinical relevance of a decrease of 1 PBA episode per day is not clear. And there was substantial attrition with the higher dose of dextromethorphan compared to the lower dose. And most of the attrition was due to withdrawal of consent or adverse effects. The intention to treat analysis was used for the outcome assessment, so it's not clear how they handled missing data, and they didn't report confidence intervals for any of the results. Next slide, please. The biggest side effects were diarrhea and dizziness compared to placebo, and then all the other side effects that are listed on this slide. Next slide. So the recommendations are to implement PA criteria for new Dexta to define medical necessity under the EPSDT benefit, and then to maintain the designation of new Dexta as non-preferred on the PDL. So if we go to the next slide, we'll talk about the PA criteria. So basically, we just want to make sure that it's to ensure that the drug is being used appropriately in indications that are supported by the evidence, and then allow the EPSDT benefit. Next slide, please. So we just have the 3 questions here. What's the diagnosis being treated? Is it for the FDA approved indication? And if it is, then we'll go to, are they eligible for EPSDT review? And then on the next slide is the standard question about EPSDT. Is it of sufficient severity that it impacts the patient's quality of life or function? And then we also want to make sure it's prescribed by a neurologist, and that the baseline number of laughing or crying episodes is documented. And we would approve it initially for 6 months to make sure that the drug is actually working. And then we do have renewal criteria, and the renewal criteria, we would just ask, is there documentation of an improvement in the PBA episodes as assessed by the prescribing provider? And that's all I've got. Are there any questions from the committee about this drug or the evidence behind the FDA approval for this drug?
Good job, Deanna. Any questions for Deanna?
I just want to point out, I had a typo on the slides. The inclusion criteria was anybody aged 18 to 80 years of age. That's on the comparative evidence table. I just had that typo. So we could go to the next slide that has the recommendations, I think. Here we go.
Again, we're proposing implementing PA criteria that has a pathway currently for the EPSDT and will be used going forward, and to designate the agent as non-preferred on the PMPDP. Questions or a motion?
This is Jeannie. I'll make a motion.
And I'll second.
Thanks, Doug.
Oh, sorry, I couldn't get off mute fast enough.
I wasn't sure if you still had power. Good job.
No, no power yet, but I'm sitting in my car charging my phone, so that's working fine.
That's creative.
Well, I was trying. I'm like, okay, where can I get power?
Get to write your car off as office space. Good job.
Yeah, perfect. All right, all those in favor?
Aye. Aye.
Aye.
Aye.
Okay, anyone opposed? And abstain? All right. Thank you all.
All right, great job. We have got through the agenda that we had planned. We're going to go off into executive session to discuss a couple classes, and then we'll come back into open session. I need to read a blurb, and then we'll go to the breakout room. So the P&T Committee will now meet in executive session for the purpose of consideration of information or records that are exempt from disclosure by law. Executive sessions held pursuant to RS 192-660-2F and ORS 414-356-1 and 2, which allows the P&T Committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class. It's necessary for the committee to make final recommendations or to comply with the requirements of ORS 414-353. Representatives of the news media and designated staff should be allowed to attend the executive session, and all other members of the audience will not be permitted to attend. Representatives of the news media are specifically directed not to disclose any of the deliberations during the executive session, except to state the general subject of the session as previously announced. No decisions may be made in executive session. At the end of the executive session, we will return to open session. All right, the committee and staff are returning from the breakout rooms, so give us just a second to get reoriented and get our phones unmuted. Do a head count and make sure you get the phones unmuted so we can take a final vote. All right. So we have concluded reviewing prices in executive session. We had 2 classes that were reviewed. I'm going to lump the recommendations together. So for the actinic keratosis class review, after review in executive session, the recommendation is to make the 5% imiquimod cream and the 5% 5-FU cream preferred, and to make all the other agents in the class non-preferred. And for the drugs for dry eyes disease, the recommendation is to make all the products in the class non-preferred. Any questions or discussion on those 2 recommendations? And if not, entertain a motion to approve both of those.
Motion to approve.
Appreciate it, Doug.
Second.
Thanks, Mara. All right. All those in favor?
Aye.
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 Anyone opposed? Abstain? All right. Thank you all.
Fantastic. Well, that concludes the June P&T meeting. The next P&T meeting is slated to be held August 7th. We will post draft materials in about a week. But again, really appreciate everybody's dedication to this important volunteer work. And yeah, glad to give you an extra hour and 15 minutes back in your schedules. So thank you all.
Thanks, everyone. And thanks, Roger, and the rest of the Derm group for all your hard work.
Absolutely. Good luck with your power.
Thank you. All right. Bye.
Bye.